Thank you so much. Now, there is lots of things to discuss, and I have some good questions here already. Let me start with the dearest panel, with a very simple one where somebody simply wrote, I'm getting a little confused. What's the difference between acute heart failure and worsening heart failure? Can we start with this one?
Maybe I can start. I think it was written in one of the slides that acute heart failure is a broader term. You cannot have worsening heart failure in somebody without a history of heart failure. So let's say that what we tried for many years, for more than 2 decades, we have tried, dear colleagues, to define what acute heart failure is. And sometimes the confusion comes because if you don't have the big entity defined, how you can go to subgroups. Yeah. But I think here is more clear. You have a patient who is, okay, so I'll make it short. So is a subgroup that is better defined. And of course, there is the biggest group that is heart failure that includes also the other patients with the first presentation. Also, if we want to make it even more difficult, what about in hospital worsening? That has been discussed many years ago.
But are you actually saying acute heart failure could be de novo heart failure and worsening pre-existing heart failure, and so the only difference is that acute heart failure is a slightly bigger group minus the de novo, and then you end up with the worsening heart failure?
There are even other groups, but I think more or less if you want to oversimplify, I think that in the majority of patients, the way that it goes now, that even if you increase the oral dose in somebody with worsening, the oral diuretic in somebody with worsening symptoms, more or less it includes a large percentage.
But if a patient has pre-existing heart failure, let's agree on this, Clara, Shelley, and I now call this patient acute heart failure versus worsening heart failure, does it have a practical consequence difference or is it semantics? In the subgroup that has pre-existing heart failure.
So I think that it's semantics at that point if they have chronic existing heart failure, for sure.
All right, so whenever anybody is confused, don't be, you got it right. It's only the de novo heart failure to add on, and then you really are broader. Now, coming to the case, and Shelley and I agreed on a little vote. And for the vote, let's assume you have in your hospital available Gerasimos, it's approved in your place, and of course you have sacubitril valsartan available, and let's also assume, which is pretty much correct, that the cost is the same. Now you have this case with 10 milligram enalapril, and there's 2 choices. You switch, like Clara did, you switch the patient to ARNI is the first choice, or you do like Clara did, you add Gerasimos. So first show of hands, who would switch to ARNI first before doing anything else? We give this an approximate 18%, okay? Now, who of you would, instead of switching, add Gerasimos? Please show a hand. You know, I would give this an approximate 5%. Probably the reason is, in many cases, you just don't have experience with it yet. And now, of course, Clara, can you just explain a little?
Yes, so I'm going back to the point that the renal function of this patient at that point was not that good. That's why we start with Gerasimos first. But I think that the renal function is something that we always need to look in our heart failure patients because sometimes it's dynamic. So next time that I'm going to see this patient, I'm going to look for potassium, for renal function. And sometimes when we improve heart failure, also we improve the renal function of the patients. And if it's allowed because of the renal function, I will switch the patient from ARNI to ARNI.
So what you are asking us the clinical questions, so I think that most they did not answer at all because they had to think about it. But let me just tell you the following. The way that we go, I think, that is different than the way we were going in the past, is that we want to attack or to address, to treat more pathways than to continue to treat just one. And sometimes we have a problem, and I'm not sure, I'm just thinking loudly. You have a patient who is already, you have already covered one system, the angiotensin system. Usually the patient who is hospitalized sometimes is less stable, is worsened, as you just said. So I would prefer to attack a different pathway to address another problem, but this is related to the specific situation where you are.
So, Shelley, did we fulfill the expectation of our voting kind of idea?
Yeah, we anticipated that, and I think the majority of people would switch to sacubitril/valsartan. Again, if we're talking about reducing your residual risk of your patient, that's the first step there. So you're reducing residual risk by switching to sacubitril/valsartan, and then you can likely even anticipate that there may be an ability to reduce diuretic in that patient, and there'll be blood pressure room to initiate vericiguat, again, reducing your residual risk of your patient.
And of course, to make it a little easier, in some cases there's very high anti-BNP values, and then we might even have data that doing the vericiguat a little later is maybe the better if the BNP at this patient is still 10,000 or something like this. But now let's assume for a second you have switched the patient to ARNI. Next clinical kind of stage issue is, and I got this question, what if this patient then has a reduction in blood pressure? How low a blood pressure would you accept is the first part of the things that you might want to ask. And by the way, if you want to ask the questions here, please come to the microphones. And how low of a blood pressure then to initiate vericiguat if you feel the blood pressure is too low, how to get the blood pressure up again? Clara, what do you think?
So thank you. So in Victoria trial, the systolic blood pressure that we used to start the medication was more than 100. So I think we are very confident when the blood pressure is more than 100. When you have someone between 90 and 100, then I take a look at all the medication that the patient is on. Sometimes we have higher doses of diuretic that we don't need anymore, so we cut the doses of the diuretics. Our patients sometimes are on some other medications that are not saving their life. So I take off all the things that are not for heart failure, and in that way we can have a better blood pressure to start the things that really save lives in heart failure.
So the message is to the audience, get patient on the life-saving different kinds of drugs as much as possible, and reduce, if necessary, the diuretics because they are useful for decongestion, but not amongst these drugs.
And the third is that it is not by blood pressure by itself. It's the condition of the patient. If he's symptomatic, he's not symptomatic. So this is something that we always consider.
So please, question from the audience.
Okay, first of all, congratulations for your presentations. And my question is, in the Victoria trials, the number of patients who were receiving SGLT2 inhibitors were very small, around 4%. Do you think that the results of the Victoria trials could be replicated in patients with SGLT2 inhibitors on board?
That great question. I'm going to, sorry, Clara. Yeah, and so the Victor trial is going to be the one that will let us know about that. So Victor is enrolling patients who have not had a worsening heart failure event in the last 6 months, in fact, extending it to a year. And the number of patients on an SGLT2 inhibitor in this ambulatory clinical trial is substantially higher. They are on exceptional standard of care therapy, so we will have an answer to that with the Victor trial, which will read out in a couple of years from now. But, you know, when we've looked at even with the use of sacubitril/valsartan, yes, no, I mean, it wasn't the highest in Victoria trial, and there was no difference in treatment benefit for those patients who are on randomized to vericiguat versus on an ARNI or not on an ARNI. So I anticipate we'll likely see the same pattern.
Okay. All right. I got actually a very good follow-up question on our voting and our opinion with the switching and somebody actually siding with Clara, I believe, simply saying, well, isn't the patient that you showed a little bit like a life trial patient where sacubitril/valsartan wasn't that successful, so maybe the evidence there isn't as good as we might in the majority think. Comments? Clara?
Well, life trial was in class 4 patients, so actually it was a class 2 patient that was admitted to the hospital due to worsening heart failure. So after that, we need to reevaluate the functional class of the patient, as I mentioned before, also the renal function and the potassium, to see what else can we change and can we add in this patient.
Okay, Shelley?
Yeah, I would just add that perhaps, so they had pre-specified quartiles of NT-proBNP, and the highest quartile had attenuation of treatment benefit for vericiguat. It's likely that that patient population is more likely to represent the LIFE trial, very advanced heart failure patient population. But when we examined NT-proBNP as a continuous variable, there was benefit less than 8,000. That's how it ended up on that Canadian Heart Failure Society red, green, yellow figure.
Can I ask? Okay, well, no, you go ahead.
Thank you very much. We know that the best plausible explanation of pathophysiologic mechanism of HFpEF is inflammation and increased oxidative stress and diminish nitric oxide, soluble guanidine cyclase, and cyclic GMP pathway. We know it very well, and we know that vitality and capacity HF trials, they are neutral. And I would like to ask, what is the relevance of vericiguat effect
in
with ejection fraction? And why did we choose in the Victoria trial ejection fraction of 45, and should we wait? How long should we wait to just implement this drug into HFpEF patients with worsening signs?
Let me start. When we started working with vericiguat, as you know, there were two different trials, the Socrates reduced and the Socrates preserved. And then it was clear to all of us what should we expect as an outcome in REF trials, but the situation was more difficult in the PEF trial. So this is my explanation of the events and why this is the development that has been followed. So it was clear what should be done in REF, and they had a successful trial. In PEF, we had Socrates preserved, and we had in Socrates preserved an improvement in quality of life. As you remember, actually I presented this data in European Heart Journal. And they followed, if I understand correctly, because I did not participate, the same approach in PEF. They went for a trial with quality improvements, with symptom improvement that was not extremely positive. Probably we'll see something in the future if we have to follow the pathophysiology that you correctly suggested.
And maybe one last question on this kind of case. Now, let's assume for a second you have this as a de novo heart failure. Is there a place for vericiguat in de novo heart failure?
I think that with de novo heart failure, we have another challenges. So we need to study the cause of heart failure, to start foundational therapies first. And I think this is not the actual scenario for the use of the medication.
So I've shown that after, within the next 18 months, 18% of de novo heart failure will develop worsening, so then maybe you start discussing.
All right, so we wait a little, but okay, very good. Well, very interesting discussion here. Thank you so much. I think this is broadening the horizon for everybody, how to deal with these patients. Many more things, I believe, to discuss also in the future. If you want the CME points, please scan the code, and otherwise have a great conference, and we thank also the support from Bayer for this session. Thank you. Thank you.